we are a little bit delayed. I will be beginning in two languages because of some people on the Zoom. I would like to welcome all of you. Thank you for attending our EIT Health morning health talks. It will be kind of intimate meeting, but hopefully really good, merit-fueling health debate. My name is Katarzyna Kotowska, and I am employee of Faculty of Management, Center for Socially Responsible Innovation, and I am a project specialist in EIT projects. Here is Piotr Nawrocki, my colleague, our main contact of the University of Warsaw in EIT Health. I jeszcze raz po polsku na wszystkich. Witam wszystkich Państwa i dziękuję za przybycie na nasze spotkanie EIT Health Morning Talks na Uniwersytecie Warszawskim w ramach projektu realizowanego na Centrum Innowacji Odpowiedzialnych Społecznie. Nazywam się Katarzyna Kotowska, jestem pracowniczką projektu EIT. Mój kolega Piotr Nawrocki, główny koordynator EIT Health na Uniwersytecie Warszawskim. Chcielibyśmy zacząć od zaakcentowania tego, że od bieżącego roku mamy na Uniwersytecie Wydział Medyczny i na początek chciałabym poprosić o kilka słów wstępu na temat wydziału, głównego koordynatora naszego wydziału, pana profesora Zbigniewa Izdebskiego. Tutaj może będzie.
Dwie sekundki powiem.
Tak. Dzień dobry Państwu, witam bardzo serdecznie. Dziękuję także za zaproszenie na dzisiejszą konferencję i bardzo się także cieszę z tego, że istotnie na dzisiejszej konferencji możemy zaakcentować obecność Wydziału Medycznego na Uniwersytecie Warszawskim. Proszę Państwa, od października tego roku akademickiego rozpoczęliśmy kształcenie na kierunku lekarskim. Można powiedzieć, że jest to powrót medycyny po kilkudziesięciu latach nieobecności na Uniwersytecie Warszawskim. Był w okresie powojennym, mieliśmy jeszcze medycynę, później ze względu na zmianę struktur uczelni naszego Uniwersytetu medycyna została wyprowadzona, utworzona została Akademia Medyczna, tak jak w większości uczelni w Polsce. Dzisiaj chcemy kontynuować te działania o charakterze edukacyjnym. Chcemy wrócić do tych dobrych tradycji, kiedy my mówimy, że uniwersytet jest pełny w obszarze kształcenia, kiedy mówimy i o filozofii, o prawie, i o właśnie medycynie i innych ważnych naturalnie także kierunkach. Proszę Państwa, medycyna na naszym uniwersytecie mogła powstać dzięki zrozumieniu Senatu Uniwersytetu Warszawskiego, poparciu Senatu, jaki Senat udzielił inicjatywie rektora naszego uniwersytetu, profesora Alejzego Nowaka. I mam takie poczucie, że medycyna czy kierunek lekarski powstawał na naszym uniwersytecie w dobrej atmosferze. Chcieliśmy zainicjować powstanie tego kierunku, aby również w większym stopniu doprowadzić do integracji różnych działań podejmowanych na naszym uniwersytecie, które są związane z medycyną. Dzisiejsza konferencja jest niewątpliwie tego przykładem. Referenci uczestniczący także ze strony Uniwersytetu Warszawskiego są tego przykładem, że w różnych obszarach naszego medycyny klinicznej, w obszarze zdrowia publicznego wpisujemy się w ten obszar zdrowia i podejmujemy szereg inicjatyw. I właśnie dlatego też proces kształcenia na kierunku lekarskim na tle innych uczelni, bo jak wiecie Państwo, przecież kształcimy na wielu uczelniach w Polsce. W tym roku był szczególnie duże przyzwolenie na otwieranie czy inicjatyw związanych z otwieraniem kierunku lekarskiego. Natomiast kierunek lekarski na Uniwersytecie Warszawskim chcielibyśmy, aby szczególnie wyróżniał się skoncentrowaniem studentów już w czasie studiów na realizacji projektów badawczych. Student kierunku lekarskiego zobowiązany będzie do uczestniczenia co najmniej w jednym projekcie badawczym w czasie studiów, bez względu na to, w jakim obszarze te projekty będą. Niekoniecznie muszą być w obszarze klinicznym, one mogą dotyczyć obszarów zdrowia publicznego, nauk przedklinicznych, ale chodzi o to, żebyśmy mieli studenta, który będzie dobrze mógł być wdrożony w proces badawczy już w czasie studiów, a jednocześnie, żeby uwrażliwić również naszych studentów na problematykę dotyczącą humanizacji procesu leczenia. A ta humanizacja procesu leczenia szczególnie była, ta potrzeba szczególnie była widoczna, jak Państwo dostrzegliście, w okresie pandemii COVID, w okresie szczególnym w relacji lekarz-pacjent czy lekarz, a cały zespół terapeutyczny. Dlatego też włączyliśmy wiele takich modułów, które będą mogły usprawnić proces dydaktyczny w tym zakresie. Jako kierunek lekarski w sensie bazy klinicznej będziemy korzystali z Warszawskiego Wojskowego Instytutu Medycznego i WIM będzie, czy jest naszym podstawowym partnerem w obszarze kształcenia klinicznego. Podpisaliśmy także umowę z wieloma innymi placówkami, między innymi ze Szpitalem Południowym, z instytutami badawczymi zajmującymi się problematyką zdrowia. I te inicjatywy nasze związane z chęcią współpracy nie będą dotyczyły tylko tej chęci współpracy w ramach uniwersytetu, ale także z innymi placówkami badawczymi i placówkami również zagranicznymi. Od tego roku akademickiego w Polsce zostały wprowadzone nowe standardy kształcenia na kierunku lekarskim. Te standardy będą obowiązywały od przyszłego roku akademickiego, teraz zostały upublicznione. My do tych standardów niewiele będziemy musieli się już dostosowywać, ponieważ wiele z tych kwestii zostało już w programach kształcenia zostały uwzględnione. Jeszcze raz chciałbym Państwu życzyć jak najlepszych obrad. Liczę na współpracę również z naszym wydziałem. Z niektórymi z Państwa mieliśmy okazję już się spotykać na etapach tworzenia kierunku lekarskiego na Uniwersytecie Warszawskim. Także jeszcze raz życząc Państwu jak najlepszych obrad, wyrażam nadzieję na współpracę z naszym wydziałem. Wszystkiego dobrego. Dziękuję za zaproszenie.
Thank you for that introduction of Faculty of Medicine of University of Warsaw. And now I would like to ask Joanna Broy from EIT Health for short introduction EIT Health.
Thank you very much. Good morning, everyone. I'm Joanna Broy. I'm representing EIT Health. I'm my role is supporting Polish partners who are in our network and Polish startups in applying to EIT Health and other external funding and building this innovative ecosystem that we will also discuss today. Can I change slides? Okay, thank you very much. Yeah, so I consider EIT Health really like an instrument that supports creation of this innovative ecosystem, and I hope we can discuss today a bit more about it. But what's our story? We are part, as EIT Health, of a huge network of European Institute of Innovation and Technology, one of the largest communities supporting actually innovators, entrepreneurs, students, startups across Europe. And you can see we actually have different branches, let's say, of EIT Health, covering really the whole ecosystem, connecting food, digital, health, manufacturing, etc. The newest one that is still missing here, culture and creativity, the new hub, and there will be more EIT branches to come. And if we go to the next slide, so what we are trying to do at EIT Health is really to bring together the writers' mindsets across Europe and also outside. Some of you already sitting here today, and we will discuss the important topic. So we connect different stakeholders really to answer the Europe's biggest challenges in health, in healthcare life as well. So we connect together companies, corporates, startups, universities, also research and development centers, hospitals, and I'm really happy that today actually we also have representative of corporates online. Hospital will arrive soon, as I heard. University, public and private. And this is what we are trying to do, really, to answer the challenges of healthcare systems, strengthening the healthcare system in Europe, also promote better health for our patients, for our citizens, and contribute to sustainable health economy and competitive health economy in Europe. And if you go next, so how we do it very briefly, I will be happy also to discuss with you if you are interested how we can cooperate together. But in general, we really start from students, entrepreneurs, to educate them, train the new generation of talents, entrepreneurs, healthcare professionals. We also try to empower startups, scale-ups, spin-off of our universities and hospitals to develop innovative solutions and put the product and solutions on the market. And we also work with researchers, with companies to develop innovative products and solution services, and again, to bring it to the market with a benefit for the customers, or patients and citizens in general. And we, as I said, we really try to, if we go to the next slide, we really try to give our partners, different stakeholders, access to this international healthcare innovation community, to really create it together for a benefit to citizens and patients. And we focus a lot on education, innovation, acceleration of innovative solutions. So I have a few partners of EIT Health here today, and I will be really happy to discuss your experience in building with us this innovative ecosystem and what we can actually do more. But of course, for also interested entities, I will be also happy to discuss potential cooperation. And the next slide, you can see also my contact data if anyone would be interested to connect and discuss potential collaboration. Thank you so much, and I hope and I wish all of us a great discussion later on during the sessions.
And now we start with first warm-up. We will use online Mentimeter. You can use your phones to be part of our warm-up. You need to go to the menti.com and menti.com and then enter this code or use this QWERTY code. The same from participants on the Zoom. You can use the menti.com and use this code. And shall we move? Okay. So let's start with the warming up. What's your level energy today? From very low to incredibly high. Oh, it's quite high. I would say 4 and 5, and when you're a student, it's really high score. The code is up on the slide. Yeah, for one, it's our energy level is getting lower. Maybe I'm the one who is boring you. So maybe move to the another questions. Oh, it's start. So, which country are you from? Ping on the map. Poland, but Spain, Poland. Yeah, the majority is from Poland, as we expected.
As we have a local meeting.
As we have a local meeting. Okay. And now more questions about around the topic of our panels. Please rate the current level of collaboration between hospitals and higher education institutions in your region. Incredibly great. 4.
As far as working.
Yeah, it's getting worse, as we can assume that most of are representing Poland ecosystem. 3.7. Not so bad, but also not so good, I would say. And another, use 1-3 keywords describing biggest challenge in enhancing hospitals and higher education integration. What do you think? Use your imagination. Trust. I would say this important one, but let's see other questions. Like this is anonymous, so trust, data access, understanding of needs, workflow, time, culture, ethics, money, RODO, coordination, physical resistance, follow-up, money, identity, feasibility, communication. Okay. Knowledge, openness. This is really important one in my opinion. Yeah, we have a few responses. Yeah. Sure, time. I would say we can go back to this one after following a discussion and think about that. And one more question, how well do current policies support collaborative healthcare innovations? Not well, 2, closer, 2.3, 2.2, 2.1. And again, as we know, there's most of people representing our local ecosystem. It's giving the grade 2.2. So in academic nomenclature, it's not even pass.
Next up 10.
Yeah. If you would like to have any questions, you can mark them on Mentimeter during the meeting. And now I would like to start the first panel, which will leveraging academic expertise and changing hospital and higher education integration through collaborative approach. And at the beginning, short presentation from Aneta Afelt, Professor Aneta Afelt. Można, ale tym też są. Okay.
Thank you so much. First of all, I'm a geographer. I'm not a medical. I'm not from medicine, not at all. I work at the Interdisciplinary Center for Mathematical and Computational Modeling, University of Warsaw. And during the pandemic, our colleagues from our center were doing modeling for the COVID contamination in Poland. We were working also with Prime Minister, with the Ministry of Health, Ministry of Higher Education. That was a difficult but very interesting period. And in my case, I have also experience with coronaviruses before COVID epoch. With my two colleagues from France, we published in March 2018 prophetic article after doing research in Southeast Asia, saying that considering the level of human pressure on the environment, we are in phase, just in moment, before the new human coronavirus possibly enter our society. We had a big problem for 1 year to publish this article because no one believed us. But end of 2019, it was sure that something is happening, and in 2020, we were sure what was going on. And in Poland, the director of our center, end of February, organized the first scientific conference about the risk of coronavirus, of SARS-CoV-2 presence in Poland. And just after, the Minister of Health said officially that, okay, coronavirus will enter Poland. It's our fault, it's my fault. I'm very sorry. So after this introduction, I would like to show you today the results of the master thesis we did with my student, fantastic girl, fantastic lady, Nela Tomaszewicz. She's mathematician and she's IT engineer. And we counted the death excess in Poland in 2020 and 2021, comparing to the period 20 years before entering the pandemic in Poland. Those results are quite surprising in general for public, because the whole period when we suffered at the time of the pandemic, media and also science were saying that the highest impact of COVID for our society is at the east of Poland, because we get used to think that east of Poland is a remote place with many elderly people, and statistically it was the index of death was very high. But as a fact, after analyzing those data closer to look more detailedly, the results are quite surprising, and I'm really interested in the opinion from medical side why it is like this in Poland. So to show some context, because I work also in Southeast Asia countries, please let me compare just 2 slides with Thailand. Thailand is a country which is economically not on level of Poland. It's a bit lower, but it's a good country to compare it for the pandemic. If we will see the general overview, the number of cases, we will see that the number of cases in Thailand were lower than in Poland, but the dynamic is more or less the same. What was the dynamic? First, it was China, then countries from West Europe, then GAP, our safety spring 2020 in Central Europe, and was huge wave of contamination and deaths autumn 2020. In Southeast Asia, 2020 was more or less safe, because they did all the administrative challenges to close the countries, to stop the international exchange of people. So the pandemic, that was surprising, but also quite statistically quite normal, that countries around China suffered the big number of contamination starting autumn 2020. So everything was shifted. If we can change the slide, here is something really interesting and disappointing for Poland, because This is the official information after COVID deaths in Poland and in Thailand. To me, it was shocking because in United Europe, we were the country where the death excess was the highest as a number of people who passed away and as an index comparing to our society. But what was not surprising to me from geographical point of view, that we were similar to Ukraine, Albania, Croatia, Lithuania, the post-communistic countries. That was really similar as my neighborhood. If we can change. So what we did with Aneta Andrzejczyk. First of all, we asked our main statistical office for the weekly data for the last 22 years. We had those data divided on age groups, each 5 years, and in weeks. Next, we used a very good WHO document to count the deaths model, and then to count the excess deaths number of people and the results. The results first. It is clear that in Poland, statistics showing the cause of the deaths is not on a very high level, because we are causing as general health problems, and we know from our data that the cause of COVID as a reason for the individual death was not on very high level as recognition. And also it is important to say that after being contaminated by the virus, we started to be much more fragile. So it was shifted in time. They were shifted in time deaths, which were not caused by COVID, or also because we were under the lockdown. We had a problem in Poland with access to the healthcare for cancer, for cardiac problems, for many problems. People suffered in Poland for the long time, and they had no access to proper care. So we decided to not concentrate our research just on the cause of COVID, but we counted general overweight for the all excess deaths we face in Poland. If we can change the slide, how it is in Poland. On the left side, there is a demographic pyramid. So the age structure of the Polish society. What is typical for Poland are the waves. Our pyramid is not as standard as Western countries, because this is the echo of the World War II. So we still have these periods, 15, 20 years periods, when number of persons in Poland increase and then decrease. This corresponds still to the history, to the past. This part, which is here the lowest, this is last 30 years of change of the system, when the birth rate in Poland just fall down. We would be very happy in Poland to have a birth index like 2.45. As a fact, we have around 2. So 2 couples, if have 2 kids, is wow, it's high success. And of course, there is a big disproportion in between cities and countryside. Countryside, much more kids. Cities, if couple has two kids, it's really a miracle. Regularly, people have 1 kid, and that's all. The consequences are like on this map on the left. So we have a total death in 4 periods: 2010, 2019, 20, and 21. As we can see on the third level of the administrative structure, which is called powiat in Poland, we can see that the death index is very diverse. This is what media were speaking about, that in the east part of Poland, we have a huge death index. There are many people who are passing away because of COVID. This is not true. This is a fact that many people were dying, but the structure or the age where people were dying and why is absolutely different. If we can change the slide, please. What we did from mathematical point of view, we counted the standard non-pandemic period model of the deaths for total population and for each 5 years age groups. Then we estimated possible scenario for the deaths total and for each year, each age group and each administrative unit for the period of pandemic, and we compare it with the reality. If we can change, here is, for instance, the results of the model estimation for the past deaths. So we learn the model, how it works in the past. Then we could build how it should be in 20 and 21. If we can see, this is the total model for Poland. If we can change the slide, this is, for instance, the model just for Warsaw before pandemic. And if we can see another slide, this is, for instance, the model for the deaths in Warsaw, but for the age group 85 and older. We made this estimation for each age group and for each administrative unit. The results. If we can see the results, we compare the before pandemic as one and the pandemic time results for the estimated deaths and the difference with reality as these dots. Red curve is 2020, blue curve is 21. So we can see in each age group what was the reality. In which age group we had the excess deaths comparing to standard model, and in which age group the difference was the biggest. As a result, we had 9 scenarios validating the reality of pandemic time in Poland. How we built those scenarios? First, for the demographical structure, we have a medium age of the society for each pocket. In Poland, medium age is 32 years old. So we are not that old society. For instance, in Germany, this is 7 years older. In France, is comparable to Poland. For instance, in Ukraine, is a bit also younger. We compare the death index for each administrative unit with medium age for this society, and we check how this medium age corresponds with statistically significant moment when excess death started in certain age group. So we can estimate this. First, excess deaths. This is the example for Poland. I'm sorry for the quality, but scenario is here, reality is here. That was first shocking moment. Please. Here is the comparison total and age groups at the left 85 plus for Warsaw and countryside. Again, very varied environment, I would say, build those results, because if we can see in Warsaw, it was much more correspondent with waves of contamination, but in countryside, not at all. If we can,
we don't see details. Could you please describe what are we looking at?
Yes, of course. I'm sorry. On the X, we have a total number of deaths. Red curve is a model estimated model for deaths which should be present without pandemic. And this black curve is the real deaths in here at the time scale from January 2020 to December 21. So everything which is upper than the red line, this is excess death. And of course, there are periods when the number of persons who passed away is lower than model. This is absolutely normal because models in general estimate something, let's say, average without extremes. But it is also true that depending on the age we are analyzing, people are passing away on different ways statistically. For instance, teenagers and people before 40 years old, they are passing away most frequently at the summertime. The people after 55, they are passing away more frequently at the winter time in Poland. That depends on the environment and of the life quality and activities.
Do you see it correct that there is no much difference between Warsaw and Powiat Hajnowski?
Yes.
Do you have any contextual data, meaning like something that reflects, for example, vaccination rate or comorbidities to better understand the variation of the real data that you are presenting?
This is underestimation now, because this is very complex topic. In Poland, we know that the first dozen of vaccination was taken for around 70% of the society, but it was very in between regions. This is first point. Second point, depending on the density of the population, the number of contaminated people varied in between. For instance, the cities like in Warsaw, the estimation shows that one wave was equal to contaminate around 80 to 22% of the society. But at the countryside, when the density of the society is lower, but the contacts are better, for one wave, people were contaminated in between 40 to 60%. So, in some extent, the death index, which looks statistically quite similar statistically, could have absolutely local cause. And this is Powiat. So we have something like 300 plus units. We started to count for Gmina. This is the lowest, and this is the 3,000 plus, and that looks different. So it really depends the unit we analyze. But results are quite surprising. If we can change, please. So we have the parabola estimation. Why parabola, not linear function? Because kids, these first few years of the society structure, kids are passing away a bit more frequently than people who are between 20 and 40 years old. And in Poland, it is very shocking to me, comparing to other countries, that first long-term illness is starting in age statistically 35. 35. God, I should be sick. Other point, 35 years old statistically person in Poland has first long-term disease, like a cardiac problem, tension problem, allergy problem, or obesity problem. It's statistics from Poland. If we can change, please. So here are our scenario, three main scenarios. The medium scenario, when it was obvious that with growing age, the risk of passing away also naturally is increasing. And pandemic is changing in general the intensity of the oldest groups' risk for pass away. The worst scenario was the scenario where the death was expected for people who were younger than the medium age of the society, local society, regularly younger than 42 years old, and the excess death was statistically significant, starting from these young people and increasing with age group. What we can see at the results, please, we will see that on the map. This is the results. Why we were shocked? First, the worst scenario, starting to pass away young people, and the curve was very, very, very steep. 2020, not existing. 2021, 4 units with this bad scenario. Then the second bad scenario, first year just 1, second year 18. 2020 were milder pandemically than 21. The deaths after autumn wave started October, November. So it was shifted. 21 really shows the effect of the pandemic. If we can look the difference in general in Poland, comparing 2020 and 2021, the circumstances were at best scenario, not worse.
One question. Of course, I'm clinician, so I
Yes.
have some questions, of course, because, okay, so you present statistics, but the question is why there are differences occur. Because you see, we have very small powiats, and the distances between powiats are very small. Sometimes it's 20 kilometers. And why, for example, we observe such big difference between Powiat Włocławski and Lipnowski, Rypiński, and so on, that we have the worst and the best. And the distance is 20 kilometers. And I think the people are very similar. The circumstances are very similar.
I'm sorry, they are not similar.
Well, it's very difficult question, but I would say the access to the general practitioner.
Maybe yes,
So,
maybe not. I don't know.
Yeah,
This
but
is just
this
a
is the main difference between 20 within this distance of 20 kilometers. Your GP is next door and it's open or closed. For example, in my powiat, which is up north, close to Królewiec, the GP put a sign on the door. It's closed due to pandemia, which means that for
yes, because you observe that it's even better than in big cities. It's a just question because I would like to transfer data from statistics to clinical answers. Yes, because I'm a cardiologist, so we are very often talk and discuss the problem about excess mortality because it's clear we have more and more death comparing to previous years. It is clear. But the causes of death, it's not so clear. And my question is, because, for example, in Poland, generally in the East Europe, very often we recorded death due to COVID for all death with COVID. For example, in Germany, patients with cardiovascular diseases, very ill patients with concomitant, with additionally COVID, were reported as cardiovascular death with COVID. So, sometimes it is the problem that, for example, in Poland, we have a lot of death due to COVID.
But they are concerned excess mortality.
Excess is okay.
They don't look at COVID or not.
We were not interested in because we knew the weakness of the data. Also, personally, because I have a personal experience. Sorry to speak in science about belief. I don't believe at all at the number of cases registered, positive, negative.
Yeah. Yes. Of course, I agree that may be due to lockdown, that the lockdown was a potential cause of increasing death because there were problems to access help in the system. For example, to reach hospital and GP or something. I agree. So generally, we agree because in many countries, due to lockdown, hospitals were closed for planned patients, not for acute, but for planned operations, procedures, and so on. And maybe this delay was so terrible for patients.
Yes, it was.
This is under discuss at this moment. Just looking at data, because data are data, yes?
After those data, I presented myself as a geographer, and this is really significant. And my word is a word of the data, different kind of data. For instance, when I compare the number of medical doctors per unit and per the size of the society per unit, is varied. First, second, number of hospitals and number of patients. This is the second. I think, to my understanding, that those maps present the history of our thinking as individuals and our thinking as a country for the philosophy of protection and prevention. If in our society in Poland, the significant statistically age for the first long-time disease is again 35 years old, people do not understand for what to build a prevention, like going regularly for the regular medical check. If you are a cardiologist, so you know well that your patients most of the time are coming to you when it is too late or very late. That also, of course, not only. That also has results in this, because before I presented those results, I read a very good book, the health level of post-communistic countries, prepared by one of the geographers from Gdańsk University. He compared the whole post-communistic bloc, the expected life quality, the expected number of years we should live, and so on. And it is clear that our Central Europe and East Europe is different for life quality than West Europe. I am under the details to go to Sorbonne and to count the same model for France. And we are really curious because in some extent France is totally different than Poland, because we have many regions which are very well developed in terms of public health, but we have also massive central, which is a bit like Podlasie.
Yes, but on the other hand, it's great that we are different, yes?
Yes, but
because of course so many aspects play a role. So genes, of course, we are different, yes? Even our faces are different, yes? But of course, so many factors plays a role. Okay.
We are counting now economical and medical parameters, statistical parameters, to see if there will be statistical link in between, and to check the impact of the vaccination.
Yes, do you have any data on that? The impact of vaccination for the local community?
Not direct. We have the number.
Those data are strong.
The first.
Know exactly how many
yes.
doses to which
yes.
one.
That data are not bad, especially for the first vaccination periods. After, let me remind you, 20% of our society took their first dose.
And also there's other factor besides, the the data regarding who was vaccinated or not, people actually relocated a lot during the pandemic. A lot of people from cities moved out, and all of the students started work, studying remotely. Many people took a remote job. So representation of geographical location is not exactly, I think, telling us who is from the rural area, who is from the urban area.
Yes, here is a bias. It's obvious, it's clear, but those data are going after the permanent address. So if at the vaccination points they registered us under the permanent address. That is helpful, because of course we cannot track every single person. But we need to do a kind of estimation, understanding the bias. It's not easy, but my colleagues mathematicians are telling me that, okay, I should trust them.
Yes, but it's interesting that at this moment we have in Europe big wave of COVID at this moment in many countries, not only in Poland. In all countries, but very interesting that the vaccination rate is very low, not only in Poland. In many countries, Europe countries, the vaccination rate is very low. We will see the effects of such strategy. Yes, of course, the problem is that the current wave is completely different. That the virus is completely different now 2 years ago, and probably the potential complications are much not fatal like 2 years ago. But it's very, very complex, taking into account so clinical issues, not only the system, but so daily practice. Okay, it's a very interesting data for me. So okay,
yes.
I would like to, yes, it's, I think the base of very interesting debate to check such differences between small powiats. It's really the difference that maybe GP, maybe hospital. But for example, in Poland, we have much higher number of hospitals than in Denmark or Spain, for example. So,
yes, but also what we do not speak, one of the aspects is the history of our demography. And I understand from my point of view of geographer why Włocławek was such a contaminated, such a impacted. I think most of the people of Polish knows where is the Włocławek Lake. The dam was built in 1973. And Włocławek as a city started to grow up because of this investment and because of Orlen, because of industry in this region. So it was a huge migration from the countryside to Włocławek city. Those people, as a second generation, as all migrants, took the habits from the motherland to the new place, to go to the doctor and I'm dying, not with the first symptoms, to not take care about health, to not being conscious that to see with medical stuff with regularly to take care of about the health. The very same is Juchowieszów, Lubelszczyzna. It's I'm sorry for this gesture, but it's such a disappointing that we know from scientific point of view what should favor us, and we have a problem to transfer this knowledge and these habits to the society. It's really difficult and disappointing that in some extent we live in our bubble and we have no good access, no good transfer just to the single Mr. Kowalski.
But
maybe the discussion here today shows actually that there is a good collaboration, or that there are good collaboration between someone that is very technical, no, like you the statistics, you can provide the number, and doctors that are sitting here and saying, well, what does this mean? And then how should we act upon it? So
Yes.
that's why I like it's very nice that you put this as an example for the panel discussion of how can we better collaborate. And I think in general, the COVID has pushed all of us, not only in Poland, everywhere, that we actually should collaborate better, that we really start to collaborate. I always use this example from Charité. They needed to see how many ICU beds were available to take on patients from Italy or from France. So they had the Charité on one side, and they had the Robert Koch Institute on the other, and then they just crossed the street and started talking. The guy that worked in the ICU, they had done a registry for ECMOs across Germany. They had that. I said, well, where's an ECMO? There should be an ICU. So we might use that register in order to build very quickly an ICU register. And they did this in a matter of a week. So we have examples that really pushed us. These crises pushed us. That's why really, I mean, this is amazing to see that now. Exactly what you're claiming. So what's the next step? Now let's talk with the doctors. It's just the GP office closed? Is it something else? Is it something that we can act upon? Are there some more general ecosystem things that we should do change? Or is it very, very single action? But I think the very fact that you did this is already a great thing. And let me just make a very small comment on, I started my work, my professional work in the 90s on working on in a FAR project, Poland-Hungarian Assistance to the Reconstruction of the Economy, on the presence of IT system. And I was not I'm a medical doctor. I was not an expert in IT. And so I did actually travel. It was not Poland. I was at that time Czechoslovakia. And I really went from hospital to university and seeing what statistics do you have. And there was this wonderful statistic where they had put, there were 3 deaths by a cosmic rock attack. And then you say, what? A cosmic rocket attack? A death by mortality by? They said, oh, we put it there because nobody looks at this data anyway. So we just put it to kind of test the system. And I think seeing that, I mean, you had some good public health data. I mean, the East, Central Eastern Europe was known for their public health data. But I think since then and seeing this, it's kind of amazing for me. Now, having seen this 30 years ago in the 90s, and now see this, that you have data that we can really act upon. Now, the next step is, and I think, Joanna, that's why you organized this meeting here, and say, how can we start talking and start, how can we act about it? So I would like to congratulate you for the...
Yes, it's great data. The problem is that it is just data. So, for example, in Poland, we have the highest mortality on intensive care units wards. So the first answer is that our treatment is not good. Yes, this is the reason of the highest mortality. It's not true. The problem is that in Poland, we refer patients to such wards even at end stage of...
to let them pass away.
Yes.
Yes.
So in many countries, it is stop. So if we have very low probability to be for recovery, we do not refer to such work. So
it's a management issue. I mean, here we're in a management faculty. It's a management issue. How can we better manage the end of that? There's this wonderful book by Atul Gawande, Being Mortal, who describes very well what is the end of life and how can we better manage it.
It's all figured out. It's not rocket science, and NHS and other countries are really effectively reducing the rate of unplanned admission to ICU and reduce the cost of unnecessary deaths in hospital, because they can assign patient, for example, to do not resuscitate status. But it's a big cultural issue in Poland.
Yes,
because once you decide that you need to hand off your patient to the other unit, so saying you cannot handle the patient because the patient deteriorates, and you do it early enough to give a patient a chance to recover, you're perceived as someone who is incapable of making decision on your own. So it just hurts your own reputation, and then it really goes above the the patient interest, and that's an educational issue.
Yeah.
It is, of course, the money issue as well, but then we have those problems. We have probably the similar sort of history of COVID as other European countries, but we ineffectively treated the patients. It's the same thing in Poland with the automobile accidents casualties. We don't have more accidents. We simply have no ways to effectively save the patients afterwards.
You mentioned I don't know. We can start the panel already. But you also mentioned education in this area. So how actually bringing all the stakeholders together could influence the situation. So who should be the educator, in this case?
I think you made the point that it needs collaboration. And what is the response to it? Having more palliative care units and having better home care. What do you need for home care? Well, you need a better collaboration between hospitals and etc. And I think just doing these collaborative work and saying, how can we increase that, has started with COVID. COVID has pushed us to do more in this area. And building on that, I think that would be the
if I can say anything. Because now I'm based in France. I started to look at the book at the school. At the level of our college, our gymnasium in Poland. In those books, pupils 12, 13, 14 years old, they have topics in biology about the public health, not direct, but about vaccination, about sport and impact for our health, about the care of elderly and so on. So the education started very, very on a very basic level. In France, almost every single person is doing some sport, not as a professionals, but sport. For weekends, it's typical they are going for picnic. Every single person has some ticket to the gym. I have a family here. After work, very hard physical work, they spend their time on sofa and TV. I'm sorry that I'm saying something on a very basic level things, but again, as a society, and this is, I think, also this has results here. We have as Poland, but not only Poland, as in general post-communist countries, we have no tradition, we have no habit to take care of our health on very basic level, really very basic level. Good quality food, good structure for the meals, physical activity, prevention, health prevention, simple, really very simple things. And to stop to be afraid to go to doctor, because if I will go to doctor, this is the text of my personal mother, if I will go to doctor, then he will for sure find something and I will be sick. I'm not sick now because I did not face the medical doctor. To my understanding, this is one of the important results of the map. Sorry, I'm speaking about such a context.
No, but I think it's great. We have different things that we have to work on. You actually pointing out prevention, promotion, and there's a lot of collaborative effort also that we have to do, including schools and doing the education, education, also kids education, and really taking this and changing, the culture and the perception. That's one area. What we pointed out here was rather the area when people are already ill and how can we better manage when they're ill, How do you manage keeping people out of the hospital, and here how do we manage people that are already sick, and what we could even talk longer about cardiology, how to prevent, etc. There is a lot we can do, but the discussion we had here is also action, but action more in terms of how can we improve the system that is caring for people, how do we can better manage care and do the appropriate care, as you say, palliative care, home care, etc. So just in terms of your education, so maybe 2 points that we had the dean of the Faculty of Medicine here, and he said they're developing more research. Thanks for the translation that I had, etc. So I think here already in the curriculum of the medical faculty, we should be having doctors that are more prepared for how do I manage my patient. No, there's this wonderful article by Richard Boehmer on leading clinicians leading, that there's a role for clinicians to make a strategy for their, even not at the CEO level, but at their level, at the department level. What strategy do I have? What resources do I have? What resources do I need in the future? How do I change? How do I check that our change is actually happening? No, it's a very small New England Journal of Medicine article, but I think really summarizing well the role of doctors in the innovation and in managing this. Not the GP that should not close his office, but at least leave a phone number or leave an email so that he can actually continue working. So there's a lot of things in innovation role. The leading role of doctors, I think, is very important here. So that education in the medical unit, and then bringing the stakeholders together as EIT Health does. We have developed with EIT Health Align, which is the simulation, and we actually do now a simulation with the Catalan Institute of Health, which is the provider, the healthcare provider with big hospital and primary care, on how do we introduce better home care. And so we sit together and have them, you play a game, as like these Harvard Business School simulation games that we build up for how to develop ecosystem. And that would also be just putting, and that, I mean, this problem you're raising is not only a problem of Poland, we have this problem everywhere now. How can we put the doctors, the director of the hospital, those that take care of home care, the health insurance, and maybe Ministry of Health or regional government, and the patients, we put them together in this and let them play and see how can we solve this, how can we improve that. So there's just 2 ideas on how to, in terms of education, that was your question.
Yeah, and can I, we will have a break soon, but my question to this also, because I know about this project and I think it's very interesting. Can you also give us more example of the really opinions of different stakeholders, why they see this kind of programs viable, how it really helped them?
Well, we had a team actually led by one of our Polish colleagues, that the EIT Business School is also active here in Warsaw. They had done a program with the Siemens Healthineers of Central and Eastern Europe. And they all came to EIT and played introduction of a new device in a hospital. That was the idea, as you can take home care and everything. So they were all people working in the company, we put them in different boats, and so apparently when they flew back home, they were still discussing on the plane. They liked it so much. So usually the first, they would say, what is this? So what we do, we give them a small case study. It's a few pages that they have to read. The hospital X wants to do this and that. And then they get, as they start, we put them in different groups. As I said, this was hospital director or director of management team, the professionals, the tech providers, or the role of Siemens Healthineers, and then we had health insurance and patients. We give each of them at the beginning, they all read the case in general, that puts the scene. We give them 1 page of saying, this is what you want to achieve in the negotiation, and this is what you know, or what you can do, and this is your limit, or these are your challenges. And with that, they go into the negotiation. And we just did this at we had 3 days of that now and then, and you saw them kind of negotiating and trying to find a solution. And the comment of the Siemens Healthineers said, even so these guys do negotiate with hospital directors every day. They said, I never really put myself in the shoes of a hospital director to understand what are his, and that I think is the great thing. And that's like, if I would love to put my shoes in, well, what limits do I have as a geographer or as a statistician? And in the same way, what access to resources I have that I do not have. So for me, that it's very interesting to follow you and to try to put myself there. And that's maybe what these type of ecosystem building simulations can do.
Thank you for all the comments. I'm satisfied. Thank you for the invitation, because as we were speaking before, I was really curious of the point of view of medical doctors for these results, for these 20 kilometers. 20 kilometers matter.
Different, yeah.
Matter, really matter. It's from your perspective, from medical point of view, from my perspective, for the society, demographical history, for some habits, for some numbers. Thank you.
So I think before we actually start the panel discussion officially,
thank you.
We should have some break, right, Piotr? Should we keep this 11:15 or longer?
Yeah, 30 minutes.
Yeah,
About.
30 minutes. So 11:20, let's say, be back. We can also brainstorm a bit during breakfast break, right? Okay, I think we can start. Continuing our discussion. We will see which direction it will go. But my first question, because we discussed all the statistics about COVID situation in Poland, etc., and we also gave some examples of very good collaboration between different stakeholders during pandemic. And my question is, do you see any of clinicians, academia, researchers, do you see that it's still on? So the collaboration that started during pandemic, it has place still, or there are some actions that are doing together, or pandemic has ended, let's say, and we came back to the old school style of working, everyone, in the silos. What do you think? Do you see this collaboration still on? Do you see some projects that are being implemented between different stakeholders in your areas?
Maybe just a few first points, and then I let Anna.
Oh. No. That it's comments and conclusions after our talk, I think.
Yes, it really is building on that. No, like we had the example of telemedicine. No, that rose. I was following Teladoc because the international business is run out of Barcelona, and Teladoc got kind of their New York Stock Exchange shares got up. No, they actually plunged down when the vaccine came out. So it was kind of, and I know from them that it was rising, and then it kind of dropped down. And I know from the example, say Spain, that yes, it was used, but it's very difficult now to maintain that. So that maybe for telemedicine. But like just building on what we just saw, I think one very interesting aspect is that we have with the digital transformation better data, and these data were very important during the COVID time, particularly like the Barcelona municipal office. Suddenly we had access to everyday numbers of COVID infections by Barcelona districts. I never had seen this before, that I could, from my laptop, go into the database of the city and see, like, oh, there are more cases in that area or the other. I'm putting this example because suddenly doctors and others have seen, oh, it maybe makes sense to look at data. And that, I think, will go on. And there, it's particularly as we move forward in more digital transformation, this will actually continue, particularly as we look at value-based healthcare. So if we look into how good are health systems doing, in the past, the OECD reports in the 80s and the 90s looked at the number of beds, the number of doctors, and that now we know that numbers of beds doesn't say anything. It's an input measure. It's not an outcome measure. No, it's like I can throw a lot of beds and money to, but it's the way how I actually organize and manage the system and what comes out of it. Now, increasingly, we have better outcome measures. And because we have better data, that was not the case in the 80s and 90s. We did not have those data. So I think this importance, and that was our discussion as well, no? The importance to get physicians in really using digital tools so as we have the access to those data. I think that would be one point, education on digital transformation and on the use of data. We talk about digital transformation of healthcare, but many say, well, let's drop the digital because it's anywhere there. there. So we need to talk about transformation of healthcare system.
Okay.
That maybe as a first idea.
Yeah, exactly. But how to do it? Especially we had a discussion during the breakfast break about middle professionals. How and what could be the role also of different stakeholders or academia? How to kind of convince them to this transformation, right? Because we said like executives, they kind of maybe see it better that this is needed because it's needed for the functioning of the hospital, for example. But how to convince the middle professionals as well, and what could be the role, because we're talking about this collaboration between academia and hospitals as well. What would be the role of education and academia to kind of improve the collaboration also?
I think some of the EIT Health projects are the best example, where we actually put together medical doctors from the hospital that have a particular innovation, a particular thing, and put them together with academia that can develop or in a multidisciplinary team. So we have engineers, we have doctors, etc. Put them together around a defined task. So my first answer would be definitely multidisciplinary, a closer work between the faculties or the universities and the hospitals. And then I would say one fantastic that probably what we know, because EIT Health has supported it as well, and the InnoStars have been very active in it also, is as an example, the Stanford Biodesign, to use design thinking to really bring different stakeholders together around a topic, be it physician and an engineer and patients, and here you could actually use the students. To have the students, we had students sitting here. Unfortunately, they had to leave because probably they have classes. To put them in that so that they get this spirit of how do we jointly develop in the future. I think we should much more involve students, PhD, master and PhD students in the different activities that we do.
And are you actually doing it in your hospitals?
Well, I'm at a business school, but maybe the hospital they can answer. Yeah. We have one example. We have the Barcelona Tech Transfer, where we course with our MBA students, where we across different industries, but also healthcare, where we put an MBA student team together with an innovator team, and then they work together on the business plan. So that might be a medical doctor and an engineer, and then we have the MBA students, and then they actually join forces. That would be one possible setting that I could think of. But I let my colleagues answer on the hospital as well.
And so I had two points which I would love to mention. The first, that the pandemic was a very strange time when actually people from government decided that they don't know everything, and it's good to ask the question as academia. So it was so wonderful and surprising to see them coming to academia with questions. And I'm looking at the professor because you were the one who was answering many questions in terms of academia and statistics. But it was just wonderful that they had equality. So, and I don't know if it stays or we are going back to old business, so nobody is interested what academia people are.
Can I make it just a very small example to support what you said from Spain? So in Spain, we had the Minister of Health, who was actually did the MBA together with me, so I know him well, and I had invited him to give a talk. And he said exactly that. He said, I started as a Minister of Health. He started in January 2020, exactly, like a month before. And he said, and then this thing came, and I said, I had someone in charge for that. I had no idea of healthcare or the details, but I had someone in charge for that. So for me, it was how to manage that. So I found this very much underlines what you said, and I really like the idea of that. Finally, politics actually listening to the academy. Sorry.
And regarding the hospitals in not really urban area or just in the middle of the system, I would say the first step should be asking them questions. So asking them what do they need and how they see the system and what are their needs. What I don't like really when from the top of our capital city, we're going down there and say, you don't know much. We will tell you how you should run your own province hospital because we know better. It's not. I don't see it working actually, because we don't see the problems from top our big city, and there are several problems. For example, weather issue, how to get to the patient who is 20 kilometers remote and has cardiac arrest, and I don't really have measures to get to him. Those beds are important, but maybe not most important, but the communication. So telemedicine, it's working pretty nice. You asked the question during the break if it stays. Yes,
yeah.
We are. I think that it is booming in Poland, but I don't see it booming in terms of the academic hospitals. I don't really see the super professionals who are sitting by phones and helping the smaller hospitals by teleconsultation, which would be good, and they have means for that.
Just an example that I know about Teledoc because I know the director in Germany. Charité has a program where they help smaller hospitals with telemedicine support from the Charité ICU. So they support ICUs that are less complex and less complex care, but they get access to very performance. So that I think that is an example that I like, where we say we have access to very high level care, but we don't need to do the infrastructure. We can access it through telemedicine.
So I strongly believe if we ask questions to those people in the middle of the system and hear them out and then help them, it's very good starting point for collaboration. Then they are really on board.
But my question is, who should ask the questions? Who should be the entity, let's say, in charge of this getting the needs?
Who should be the initiator?
Yeah.
Who should take the lead in
exactly.
doing that? I would say the innovator. I mean, we actually, in business schools and in the different programs we talk about, I do a lot of work in global health, the global health innovator. And that's each of us. That could be a head of cardiology department, as it could be the CEO, it could be say, I see this, and then see how can we move things. So I wouldn't say it's not one person. And as a director, we had this discussion of a hospital. I can identify someone that could take the lead in making this change at their level. Then sit down, say, look, where should we go? And I think I would really like what you said. It's saying just first listening, how would you do that? This is the issue that we have. Does it correspond to the needs that you see? Are we on the same page? Is this the need I see as a director from my side? Is it really the one that you perceive, or is it different? And then say, okay, you start working on it. Make a proposal how you would like to do that. And then I give you some resources or whatever, or access to expert advice or whatever. And that's what I had called it earlier, that we always talk about there are too many pilots and it doesn't scale, that we should use pilots to scale. And these pilots in terms of giving the responsibility for the local implementation in that city, in that area, in that primary care unit, give it to the people there, saying this is how we should change, and you tell me, and then at the end of the year we look into it. Now on the other side, now we can discuss it, what are all the challenges, and we had this picture before, the resistance of doctors. It's definitely in Spain, definitely the payment of and they say they don't have time enough. No, we had that point earlier. And so we have to see how we can manage that despite the human resource issues or workforce issues that we do have. But in the end, it will probably improve also workforce issues.
I think the first answer is that we don't need money alone.
That's correct.
Yes?
Yeah.
Of course, sometimes we need know-how. Sometimes we need somebody to connect all together, because we have talked previously that very often we have very nice solutions, but we don't know that you have such solution already. Yes, I think it's not possible to create just one office or, for example, the ministry to start. Of course, it is important, but I think. In my opinion, very often we have a problem to build a network, to to talk to our colleagues, to exchange our ideas and solutions. Because even regarding hospitals, so it's very useful to meet my colleagues in many big hospitals and to talk about solutions and just question what to do, what did you make, and something. I think at this moment it is, in my opinion, a very big challenge.
Yeah. And are the executives of hospitals, let's say, open for promoting these innovators that we are actually talking about? Or what is also the role in really, like, for example, Aneta's team, right, with projects, departments, innovation centers, etc. What's how hospitals are and academia are also open for this collaboration and promoting this kind of people and the knowledge sharing between.
We are open. We are open. But the problem is very often so. I think at this moment hospitals have something very attractive: data, big data. So I have so many visits every week. So big companies asking for data, yes, and I think so. We have so European data space and data sharing, and but I think it is still under debate, and I'm concerned. I have many questions regarding this idea, but yes, we are open. Yes, for staying business, but of course you have to remember that it's time consuming, and my team are working every day with patients. So if we have extra idea, it's very often extra money, extra time. Yes, that it's not so easy just to come to me and say, yes, we have a problem, we will do this project. Yeah. Sometimes we have very limited resources, people resources, time resources, and so on. So it's a problem to start with new ideas. On the other hand, we have talked already that every change is something, our team, our staff, afraid to change something. Because we have system, but it is our system, we are familiar with, it's okay. So using changes, so very often we have to wait, sometimes 1 year, sometimes longer, to reach effects, yes, expecting research effects. At the beginning, very often, especially with digitalization, at first, sometimes using electronic data, we have even more complex solutions and very time-consuming. So my team say, "Oh, director, crazy." I remember before it was much easier using paper. Yes? So yes, we have to explain. You have to build something, the atmosphere for our people. We have to take people with the medium. Have talked the medium level management, not executives. Because executives, it's very, I think, simple and acceptable. But we have a problem with medium level executive to explain why we do something and what we expect. Long.
And then we have the next kind of level, the next sphere of university and collaboration of medical university with the university hospital. And absolutely, absolutely. And then we have to also think about that, because we have researchers from different disciplines ready to collaborate, but then there is the reality of a hospital where you need to cure patients, and this is your primary goal, and we come and our goals in a way a little bit
students at this moment.
Yeah.
we have wonderful examples, and the one I use is the one IVF next door is the Hospital San Juan de Diego Children's Hospital, where they have research and innovation inbuilt in the strategy, in the way of doing things. So they do simulations for everything. It was just in the newspaper. They did a separation of Siamese twins that had a very small connection with the liver, but what they did, they simulated with the whole team several times in order to view all the potential complications they could have. So everything what they do, they use simulation, and that's this kind of doing research around an action that we want to do is actually something to build up, to see that in the hospital that it makes sense to have a better collaboration with the university. You will have new ideas, you have better data, or the expert that can do the analysis of the data. So we will get to better really active results for the patient and for the people together. That's how I would see how to frame it around maybe some very concrete projects that you could start with.
If I can say something more general about the question, collaboration between government and scientists. I'm very sorry, the government is no more interested in the data and the simulation. I remember a conference 2021 in Poland in Warsaw. I was presenting the results of COVID from the society point of view, the vaccination effect, the deaths, and so on. It was a previous stage of this. The participants were shocked that all those data exist. So if I can say anything, that there is no, let's say, environment to know us each other, to know what we are doing, to build a good links, even not a bond, but links, what we can offer to each other. This is the first point. Second point is that each of us has a tendency to think about our own square. We do not go to look at the square of the neighborhood, or if you are looking if the neighborhood is better or not. This is some kind of social point of view. But we do not look on the let's say global scale what we are doing independently. Where are the hot points we can see it is something similar, and to use the experience we have to propose something which will be suitable on the top, but also suitable on the lowest level. So first to share the data, but also to build new models, new predictions. For instance, we have a cardiovascular problems, we have obesity problems, we have a problem with allergy, and so on and so on. Each hospital on each level has a lot of data, but those data are of different quality, different databases, different topic, or just a documentation. This is the richness we are losing because the databases are not comparable in many cases. We made my center with university, with a medical University of Warsaw, with pediatric unit. We made the first important database about the inflammatory syndrome for the kids after COVID. Mm-hmm. It was the first database globally. We were just after American and British. We had the best ever, the most credible database. And so what? The case is finished. Medical staff had no money to continue the database. Okay, we kept it in our servers at my center, but no one is interested in. This is the mining of the great messages. For instance, if we would have a diabetic disease modeling for the future concerning the state of art for presence and the generation aging on the level of poverty, we can prepare the system and the economical budget for future. The same is with the elderly, the same is with many diseases which are quite basic. We do not integrate our skills as a society, and in my opinion, I'm sorry to be so critical, we are using our talents.
It's okay.
It's not a matter of it's a matter, for instance, of my master's student. She's fantastic. She's brilliant, but she's working for the US company now.
How we can change it? Is the role again of these innovators to kind of chase these stakeholders that should be aware of that? Should we also within hospitals, what we do, for example, within EIT Health when startups come, so we educate them that they have to identify all the stakeholders that are crucial for them to implement the product on the market. Should we kind of, scale it to hospitals, for example, academia, to also help with maybe just identifying?
So maybe just a quick point on for me, the so what is missing. Like, what are we doing? How do we act on those data? And that in Catalonia, that's because I know that best. That's why the example will come from there is the Aquas Institute, where they bring together all the data and then they really design actions upon it. And once we have actions, then we need more data so that we really use them and not building up. But I didn't want to interrupt you.
No, you're not. And I think it adds up to what I wanted to say. What I'm hearing, and it also sort of it comes together what we had a discussion during the break with Professor Jażdżewski. I think we need a kind of a hierarchy of thinking and a decision process, and sort of better clarify what we want to attempt. And I don't know whether this is within the vicinity of interest of EIT Health, but building a sort of guidelines, not in a very stringent way, but in a more instructive way and agile way of addressing all of those problems, because there are many problems which were covered. The involvement, the motivation, the interoperability of data, the use of knowledge, the lack of priority, the sponsorship, many things, and the funnels, how the innovation or the ideation can end up in a practical application. That requires sort of a thought-through process that maybe EIT Health might be a vehicle sort of to develop with all of those partners that we were talking about: the universities, the doctors, the regulators, the government, industry,
politics. Yes. I'm afraid to say politics.
Politics, yeah.
The policy.
I said regulators. Yes, regulators. So politicians as well, although they might be interested in this sort of very end shaking hands part. But at any rate, I think a lot of those problems are already sorted out. We need to simply not to try to reinvent the wheel, but gather the learnings from other geographies and figure out how we can apply them local. And if the big company is approaching the hospital asking for data, I mean, it doesn't make sense to give them data for free. It's just in a very it's the worst interest of the hospital to share the data by the mere fact that they possess the data. And again, the question is whether the data is representing something valuable, because you may have the big database representing the malfunction process of treating patients. So the data is crap, Sorry for those words, but it's just the matter of making sure that we understand the structure of actions that we need to take to start from one point to the next, to the end, which would be the effect that already has a buy. We've been talking about nice approach to develop solutions that nobody is interested in, because there is no owner interested in paying for the end result. So before we start the project, we have to think about the very end effect of it. And if it does not have a checkbox, we simply don't start it unless someone who's interested in that subject will change the reality in that area. So I think helping people and all of those stakeholders to understand how they can collaborate effectively and building sort of a structure of the process would be very helpful. Not everything has to land within the traditional sort of ecosystem of startups and commercialization within European market. We've been talking that some of the ideation can end up in a commercial market of US, where you have a big population, big uptake, and you are not losing anything. You're just helping some people to hone, to grow, maybe in a kind of a different dimension, but still you're helping people to move on. So that's my.
I like what you said, that it's not all about startups, and that's maybe too with EIT Health, that there's so much more to do.
Of course,
helping the ecosystem to take up whatever the startups are being delivering. So I very much like the point.
Definitely. But also like putting
Yeah, I wanted to add just one more thing, that what we would probably need to do, all of us within EIT Health and beyond, to be better prepared for this take-up, because I believe that there are so many opportunities that are lost just because of our lack of preparedness, because the idea might be wonderful, but then we have to have the system, the kind of prepared ground for making it happen. Because sometimes it's a very simple thing at the hospital level. How can we really introduce the solution from the startup? And so this is another thing that needs to be looked into.
Okay, but do you understand also preparedness in terms of education of different level as well?
Everything from the very beginning, from the bottom up.
So that what we have been claiming in EIT Health, that the education is all very. I mean, the way the call is now of saying we have to, probably read it, to repurpose existing, but it's, we use and apply it in a very well-defined way, corresponding to the needs of the people that we work with. So I don't think that the call as it is out now is useful. Let's leave it there for the moment. The education call. I think EIT Health could be doing much more, and exactly what you say, it doesn't need much. You ask about these initiators. EIT Health could be the initiator of bringing together the different players in the field and saying, well, let's together by now, let's sit around like we sit here today. Where could we start? What might be a concrete thing in that? I think is going well beyond just supporting startups, but really saying how can we change the system.
And startups is just one sort of a facet or consequence of the need that people were able to sort of articulate, they need to change, they need to improve, they need to innovate. I think what I found missing, like big time, is that healthcare systems, healthcare provider networks like hospitals, universities, they miss a concrete strategy. They have no idea how to build a strategy. They don't understand how to apply it. They have it, but it's so general that you can apply it everywhere. So in my opinion, it is just a great opportunity to kind of zoom in onto something very concrete that create the action items that we are talking about. So if you can help the stakeholders to understand, okay, I need to start with the strategy. I need to have the strategy related to the needs, to the opportunities, to the politics, to the problems that are current and need a solution. And then relating to that, I can plan my other action items. Then it would be a big change, educational change, and and it will help to streamline all of the elements that we've been discussing.
Yeah, it's always about the basis, right? If you kind of the fundamentals, let's say, if you have them created, then it's easier to kind of.
And people think it doesn't apply. It's not. Why should I think about that kind of grandiose ideas? I'm not planning to boil the ocean. So of course it's not. It's more about kind of, as I said, going closer to the reality and then trying to translate it to the needs that I'm sort of anticipating on a daily basis, so people can better put themselves into that situation. They will be more involved, they will be more engaged, they will treat it as something more personal.
Also to understanding the situation, and as also before we mentioned, putting yourself in someone else's shoes, right, to better understand the need.
So if you have a doctor, that is having very limited time for his or her daily activities, and he would or she would better spend the time with the family or other things than engaging into something that is very theoretical and cloudy with regard to the end results. You need to show the concrete value up front. And unless you will show the value that, okay, I can bring your idea to you as a market, and you can be a shareholder of the company that will give you a yield of money till the end of your life, let's say, or for the next 10, 15 years, that might be something. Or I can help you to end up as a influencer of the politics in your country, because you will, by example, show something that will change the current status quo. It is the different way of motivating people, but you need to show it up front, not to say, okay, we have so many data, we have this database, or we have those patients, we can do this and that.
I like that. So I wouldn't even go that far. We talk about middle management. Let's say, look, it's your role, your responsibility, and then recognize it. Like it could be the prize. I don't know. We have this. The Americans have the work of the week. No, I mean, some way of saying you really do something extraordinary here that would be an example for others, and you are in the driver's seat. So I think it doesn't even need to be much this type of recognition. The problem is actually like how to make time. How and our colleague here said that we don't need much resources, and then he said in another sentence, well they don't have time, they don't have the resources. I think here we actually have to see also strategically how hospitals allocate resources and actually manage and try to see how can we liberate some time by better managing, and we know, all of us know that there are a lot of room for more efficiency in the hospital, and just by starting that, liberating some time of a doctor one afternoon, that then can say, oh yeah, that afternoon you dedicate for driving this project, and that does not necessarily mean to be a startup and having shares. It just make a difference for your department, for your people, for the area that you're responsible for.
And the hospital can make a good money on research which is carried out by
that's correct.
By clinicians, by taking an overhead, and I don't think it's happening now, So if the companies see, if the hospitals see the value in having the let's say double head of the doctor working on the research and clinical position, so they can benefit from clinical services and also from the research work, and it's part of the sort of strategy that they promote it, they advertise it, they educate people. Okay, this is your career path. Then it makes sense.
I like that. That's very good.
So we have education management as a key factors for now, but
I would say the framework, if you can start.
The workforce, I think your point were really good. The workforce, that I really sit down with them. what is your career path and how can you enhance your professional growth by and not only company project, would be European. We talked about Horizon Europe, Horizon Europe project, where then this is beneficial for you, or IHI project. I mean, this is like where you can, what particularly university, hospital, physicians would like to do is publishing, then we help you to get the money that will allow you to do this type of thing.
I'm sorry, we are speaking about we, and the same we are speaking about this single person. So if to be efficient, that we need a network.
Yes.
Sure. But it's part of the framework that I was thinking about. Yes. So part of sort of the landscape or the canvas or however we call it, the understood reality and the way how we should kind of go step by step to accomplish certain things. And that would be both instructive for the hospital how to exist in such a framework, and for people who would be contributing to that. So everyone will sort of understand and can relate their role to that framework, to that canvas. That's not rocket science. It's very simple. It's something that I think through, let's say, a series of 3-4 workshops, we can have sorted out.
A line could be a good way how to get.
And that could be a task for EIT Health if that is something that.
You give me so much work.
No, I mean, so hire more people,
We asked for an education. We had this education strategic group where we really worked with other, like business school with Karolinska, with Sorbonne, in whom we worked with Leuven also on how can we do that. Actually, we had with Harvard Business School in the early days of EIT Health, we had we call it the Genie Workshop, which was why you were also there, where we really said, how do we educate the future innovator? This person in whatever place in the network this person is sitting. And I would say to have some more of these joint educational activities by EIT Health would be helpful for the whole network, for all the activities, be it innovation activities, be it accelerator and then the startups, but also with these whole inside the different skills, the pact for skills, and also at the European level to show we really make a difference because we help the system to change. Yeah.
And you don't have to do the whole work by yourself.
Yeah.
You can. And I'm pretty serious. You can build advisory board network, from the industry partners, from the clinical partners, from the practitioners, from patients, and having the advisors who are working for you towards those certain goals. You can really streamline all of those tasks. Mm-hmm. So that is something that I think is the best and most effective way to do that.
Yeah, definitely. It's again bringing all the stakeholders, right?
Yeah, but do it consciously.
Yeah, of course. But when we had the Mentimeter at the beginning, he also mentioned one of the biggest actually challenge in cooperation with hospitals, academia, trust and culture. Could you also elaborate on that? A culture for me, it's also what we discussed basically. Also the frameworks, etc., how we cooperate together, but about the trust, how you understand this in this context and how we can also work on this factor. I think everywhere it's super important, to build this.
Well, as long as we have a workforce that is still recovering from COVID and is kind of not having the time and is kind of burned out or close to, and so it's very difficult to build up trust, and to say, hey, we are on the same side, we work together. So I think it has a lot to do with sitting down and really listening. That's the point you made, on saying, well, what are your problems? What is your need? And say, how can we find a solution together? And then the next step then would be, would you like to take part into it? I think this is like any human resource management is building up the trust and culture of change by sitting down with the people. That's, I think, why education is so important. Education in the sense of learning together. So education, usually we see education as someone telling you what you need to learn. We have at YESA the innovative learning initiative, where really we see, well, how can these learning efforts together with all the different stakeholders, and that's how you build up trust.
And trust also comes with confidence, So if you're confident, you are contributing. If you're confident, exactly. You are well received, heard, sort of involved,
and it's recognized.
And recognized, exactly. That comes afterwards. So this is something that is an opportunity for, let's say, for the hospital, or for the university. If you participate in a certain activity that contributes to the goal that we are discussing, you should be somehow rewarded. You should be somehow promoted. Your case should be kind of exposed to public the way that you feel that you did something, that you did an accomplishment. So that also comes together, and if it's missing, then people may do a lot of work, and as you said, the good work, it comes very without any applause. People, if you are doing good work, nobody is looking at that. So people like a controversy. So that's why we hear a lot of noise about very small things, and it's a matter of the decision that, again, comes with the strategy. I want to promote such an action. If I have it understood that those are my goals that I need to kind of support, then I have tools that allow me to get people engaged, involved, rewarded, promoted, exposed, and so on.
And make it sustainable, right?
Yeah, and that's the only way to make it sustainable.
Because we actually have lots of discussion, we all have lots of workshop sessions, but at the end, it's my personal opinion, I don't know if you agree, but we go back to our daily work and
again,
work.
We need a framework, you need to have a roadmap from A to Z. And if you are like deviating from the roadmap, then you're taking the risk that you end up in a dead end, And you have to build it together, then it's trusted, and it's and people can position and relate themselves to every element of it.
Yeah, okay. And if I can add anything, we need a multidisciplinary.
Yes. Sure. Yeah. There are some very nice examples. We did a case study in hospital clinic again in Barcelona, but where they have divided the clinic, they have created institutes of putting all neurology, neurosurgery together in one, and gastro, like internal medicine and surgery together, and then really make it multidisciplinary with the radiologists, with the lab, etc. And they build up at a lower level the clinical team. So you have one leading doctor, one leading nurse, and they put an economist at the different departments. So your team of three, and that's a way of recognizing and putting this, like saying this is your role now. No, you're kind of not the head nurse, but you're kind of a team on managing this department, or on managing change. Or the same you can do by putting up a team that is introducing change. And it could be a multidisciplinary team, and you might even then say, okay, Aneta, was you saying that, well, how can we involve the university? Well, get a statistician from the university or PhD student that is working on it particularly, and build those teams, and that have them work together. And then you can recognize them, I don't know, when you do your yearly hospital meeting, or a public meeting, or you do some events for informing the patients. That's also a very nice way to recognize the teams, and at the same time show the patient that you make change. So there are a lot of things about that, but it's all based on this education, bringing those innovative ideas to the people.
And the good thing is that throughout our years together in EIT Health, we have the history of good collaborations and those interdisciplinary collaborations. So we have some things to build upon, and this trust is already built. So, this is also very nice point of reference for us all, that we can just come back and we can grow our teams so that they are even more multidisciplinary, with more actors, with more, universities, organizations.
And I think the value is also that, across Europe, we see the good practices, right? And it's not that we have to copy paste to our local environment because of culture, trust, ethics, everything. It's not always possible, but at least we have access, thanks to the network, also to that, and we can kind of decide what will work for us, what not, what we can contribute to other players.
This is the wonderful thing that we appreciate, although we just commented with Aneta earlier over the last years of EIT Health, that we have this easy access to innovators, the universities, hospitals, companies, tech transfer centers, that we know the person that is interested in this collaboration, and that's actually very, very nice. And I would wish that from EIT Health there's more activities that makes these connections. No, I mean, we have other ways to do these connections, or neuro projects, etc. I think this is the essential of EIT Health, that we really appreciate learning from each other, discussing on some points, etc.
Yeah.
I would say probably through COVID, and there's a lot of things that just stopped. No, we did not move. We had some online things, so I think EIT Health's network also suffered from COVID. But I think it's time to have meetings like this. I mean, I came because I really like this type of meetings and see and interconnect. So I would wish that we could do this more.
Yeah, and I think EIT Health has strong credibility, and it's and it's recognized well enough to invite to that discussion, or to that whole sort of effort to begin with, and can sort of attract stakeholders that are also relevant, not just random, but relevant.
Yeah. We will be closing soon, but so you're not mad at me. But I really like the discussion. So how the organization outside networks like EIT Health can also, how you work, educating, bringing innovation to your hospital, how you trying to do it? Can you also elaborate on that, maybe? Yeah.
I'm not a hospital, so I don't know about
Or is it hard to really kind of, change the mindset also of people in hospitals? What kind of tools you are using to do it?
Start with inviting them to such a nice meeting. And then when you have those people aboard, it's easy to discuss their troubles. And the second thing is always we need to give them some incentives, because they upfront they are paying for it. They are giving something away. So this trust means that they need to trust us that they are giving away, but in the end they get something in return. And it might be recognition, it might be some real benefit, it might be just being part of something important, which I believe is going on here. So another thing, I don't think we need much. We just need to see them as partners and keep them out.
And I'm sorry, just that to your point, the tangible value is the end result. If we can articulate the end result and value of it, I think it's more than enough to attract people. Because I think everyone is suffering from lack of understanding the entire landscape and how they fit to it. And once you have a better understanding of it, this is a great value, because you can better position yourself, you can be more effective, you can do all of those things that we discussed. So I don't want to originally
I would say the successful organizations usually have been very good in identifying exactly this person or persons in their hospital that would like to innovate, where there's this fit between their professional growth or their wish for professional growth and the change as hospital what we want. And I think the good leader in those hospitals that have done this successfully have been able to identify those and like bring them and maybe give them some additional training. Like in the different projects that we do, such as the Halan project, we have several ones. These are medical doctors that work in the institutions around, and whenever we call them, they're there because they want to be there and they're driving and helping to drive, and they're not necessarily CEO level. No, they help to drive that, and I think that would be my first guess. Would be to look at what makes those hospitals successful is really identifying people that would like to do this extra mile despite all the challenges, and once we have them, then we have the internal drive to make change.
If I can say something about my practice, when we built the post-COVID inflammation kits program database in Poland, first pediatric doctors were linked with Warsaw University. That was the first match. There were just two person. There were 4 persons, and finally we published a very good article in Nature Reports.
Yeah.
We had 150 co-authors. Each of these persons from hospitals from the whole Poland were put under the name, under the hospital. We had the database. We did also the public presentation at the Nicholas Copernicus Center about this project, about this disease, how to protect, and so on. So, if I can say anything about public recognition, this is extremely important.
Of course.
First, research article, then existing in public, existing in social media, existing as a website, as a project, as a kind of portfolio, because it's very helpful, for example, for applying for the new job, applying for the new position, or advancing, developing the career. Colleagues, medical doctors I co-work with, they are now in universities in Harvard, in Oxford, and a part of the portfolio is the experience of working as a medical professional, but with science, with something else, with something more. So that was a kind of a fruitful effect they could build, as you mentioned, career, simply career.
And that should be part of that framework that I mentioned. So that should be kind of an element that, it is a trigger for all of the what you had mentioned.
Yes, but also recognition at home. So to make sure that the hospital or the university really highlights that this is an achievement, that they are proud of you, and that this is something that is really being shown to others as this showcase that they could follow your example. Because sometimes people have successes, and then, they themselves are a little bit afraid to talk about them publicly. Of course, there's LinkedIn and other social media, but it's not enough. We would love to have this recognition of the university, of the hospital, so that they see that this is something that is really supported by the organization in which you are. Because then, of course, you have this international recognition, but this is, of course, the result of this joint work at home.
Yes, but it started from a very simple thing. It was just one call from the Ministry of Science, and it was then after just one call from the journalist, and it started.
Yeah,
And then we all live together, yes. And,
but this is the type of initiative that we would like these initiators to do. They have an idea and they said, this is a good thing, and it doesn't need the approval of the hospital director. Said, let's do it, let's go for this, and you just drive it because it makes sense.
But you actually had already the end goal, the end result tangible, so you had the interest of some ministry, as you said, or well, I don't know what was the history, but you just mentioned that there was someone who kind of showed the need for that.
It was more simple and more complicated at the same time.
No, I'm not saying that it's pretty simple and it's always the same way, but you had a goal in mind. You had already goal in mind. If you don't have a goal in mind, then it doesn't make sense to start the work.
Something concrete that you work on. And not that, we should do more and we know it. That concretely, this is not what
first concrete, but to be brave also.
Yes.
The individuals to be
kind
brave.
of support the group, let's say, right?
Because, of course, I remember for this initiative, there were first 3 cases in Poland for kids' inflammatory effect after COVID. Just first 3 cases, one in Wrocław and one in Warsaw, and 2 in Warsaw. And the ladies, the pediatric doctors, knew each other, and they were online with the global message that something is happening, Kawasaki like this. And when they started their initiative, just 2 persons, and it was on the level that they needed someone from outside the hospital environment or medical environment. They wanted someone from science point of view, statisticians, mathematicians, IT guys. Again, it was contact one by one. And what is needed is a frame that, hey, we are here. If you have a need, tell us, we will find you a partner, trustful partner. Because we were ready to link each other. And that was a fantastic story. Those 2 pediatric doctors, they were, the one is after PhD, one was just freshly PhD, so they knew the value of the academic career for their medical career. That was the first step. Second step, by chance, we had someone in common in between University of Warsaw and Medical Warsaw who knows 2 sides.
Yes.
And this is the platform to call to. Please help me to find someone, or I have a need.
But I think we will have planned very soon, or a break, or we have to. I'm looking at Piotr just to asking for. Thank you very much for the discussion. I have like 5 pages of notes as a homework for me. So that's really great. But a final round, I would say the most important action point that we should as a community also do quickly, let's say, for your goals of your institution in terms of this collaboration ecosystem, innovative ecosystem building. For me, it's definitely strengthen the network, show more success stories of our partners, EIT as well, and the education. For really, it's the key also to bring the stakeholders in terms of education together. And then,
thank you for the invitation. You mentioned to discuss my statistical results with the specialist. And this is really funny to see the different points, medical point of view, and a bit from demography, sociology, the history of our society point of view. I would say we need to link our experiences to see what we can win on the end. Because from perspective of quantitative methods, there are many opportunities and possibilities. But we have no knowledge, which is on the other side, from medical side, to understand the results. Thank you.
Thank you.
So thank you also for inviting us. Well, what I would say is, of course, building those bridges between all the different actors, participants, understanding their needs and the value that they can bring. But also making sure that we are all prepared and we are all on the same page regarding different aspects of making this innovation not only happen, but really settled within our ecosystem.
Yes, it was a pleasure part of that event. So it was a great opportunity to learn from others. And I think what I had I will be just paraphrasing what I said. So I think we need to leverage the experience and knowledge that we have as individuals, and then we build together the momentum for others to step in and to contribute. I think people are willing to contribute. We just need to show them the easy way to accomplish that.
Yeah, I'd like to cite from this wonderful book on the interaction field by a former colleague of mine. He's now in New York at the Vivaldi company, Eric Joachim Staller. So he did this book on saying we no longer should compete, we should interact and develop these ecosystem fields. And so what he says is actually focus on a big enough problem to solve, which is what I said, like really focus on something, not take something, ensure that all its central partners are on board, like really look into who should be involved, select the right orchestrator, the initiator that you said, no, that could be the health insurance, it could be the hospital director, whoever that would be, but someone that has enough power and can create this urgency to act. No, then build up the critical mass and scale, and then looking into. He describes several examples in this book also on like where do we have the data, which was your point. How can we bring those data together and really then make it sustainable? But the main point is something concrete that is relevant to all of us, and let's start there, and then we show that it works. That might be my idea. Yes, you have the last word.
I really enjoyed the data mortality during the COVID time, so thank you for that very, very much. For sure, we need more people here from different societies or the group of stakeholders. I mean specifically about the people from non-academic hospitals, to bring them here and listen to them and ask them what they need and how they believe to contribute. So this is what I'm looking for.
Great, thank you very much. Also, sum up.
So I would like to thank you all for the discussion, and I would say, like, maybe not honest that we did a good work, we create good orchestra here. Maybe it's not the critical mass, but like all the ideas, discussions, point of views, like the data center point of view, the like more medical point of view, like compared to ecosystem Polish and Spain one, was, I think it's a good starting point. And the idea of bringing up the non-academic medicals also here, it's also a good point to remember for EIT Health for the future. Thank you all for the coming and for such a rich collaboration. Piotr, anything to add?
Thank you for organizing it.
Thank you for trusting EIT and inviting us.
You know, we represent education sector, so we can only support you, all the stakeholders, and with the help of the EIT Health, it's much easier to reach the relevant partners, to find the new ones, and not only in Poland but also in all who work in a risk, in general, in a risk country. But it's quite important. It's we joined it last year to EIT Health, and I think it will be much more active year by year, because we see that the value of your network and what you represent.
Thank you so much for organizing and bringing such a lovely guest here. Thank you so much. We see each other next year. Like, I'm laughing that every year at this time of the year, I'm in this room, with Piotr organizing something. So definitely next year we have to repeat.
I hope to see you maybe earlier than end of the next year, but we try to plan a minimum 1 or 2 events. Let's see how it happens.
Thank you.